of the educational series from the Education Committee of the Ped Section, run by Dr. Leonard, Dr. Durham, and Dr. Limbrick. Today we have our special guest lecturer is Dr. Brockmeyer, who almost needs no introduction. He's had multiple leadership positions in pediatric neurosurgery and is a leader in the field of pediatric spine, not only clinically, but really pioneering collaboration in research and advancing clinical outcomes for the whole field altogether. So without further ado, we're going to have a lecture first by Dr. Brockmeyer, followed by 3 cases presented by young faculty around the country. Thanks, Dr. Brockmeyer.
You bet. Thanks, Sandy. Thank you for that nice introduction. Let's see if we can get to sharing here. Everybody see this okay? Okay, fantastic. So yeah, thanks for the opportunity to speak. And I wanted to thank the Education Committee and their kind invitation. I was thinking about this talk, and I've given this talk or a version of this talk multiple times over the last 28 years. And this is a good opportunity for me to review, what I know and update the talk, given recent advances in the field, in just sort of an overall a picture of how at least I approach craniocervical injuries in kids. So greetings from Salt Lake City. I'll see many of you in the upcoming days at the Pediatric Section. We have national parks and we got winter activities and summer activities. And this is our humble hospital, primary children's hospital, nestled against the Wasatch foothills. So we look forward to seeing many of you and hosting you next week. So by way of introduction, we're going to talk just quickly about general concepts of cervical spine clearance, which is really important. We're going to talk a little bit about biomechanics and then how to go about evaluating traumatic craniocervical injuries. And then probably the most important part is just surgical decision-making. I think most people in the audience, I see there's residents and there's also grizzled veterans in the audience, and most people know how to do the procedures, like who to operate on, and that's some of the most important stuff you need to decide. And then we're going to talk about some specific injuries and specifically about the concept of SCIWORA, which I think is fairly interesting, and then a little bit about surgical approaches and techniques. All right, so the ideal cervical spine clearance protocol does 4 things, and it identifies all significant injuries. It minimizes unnecessary radiation exposure to children, the image gently concept, and it allows you to remove hard cervical collars or other methods of immobilization when they're no longer needed. And it efficiently and effectively utilizes resources. So with that in mind, there was a group of physicians a couple of years ago that got together. One of them included Dr. Leonard's wife, Julie Leonard, who's an emergency room physician. So it included ER physicians, general trauma surgeons, orthopedic surgeons, radiologists, and neurosurgeons. And we came up with a sort of a consensus-driven cervical spine clearance document, which is published in JBJS. And I think this really works. And there's 3 entry points into it. There's this Glasgow Coma scale of 14 to 15, which is heavily driven by the nexus criteria. I'm not going to go into that in detail, but here's one entry point, and there's sort of the severe injury entry point on the right-hand side, which is more imaging, CT imaging driven. But the point of showing this slide is that there's 2 places that we get involved, and that's here. So if there are abnormal X-rays, either through this pathway or an abnormal CT scan or an MRI through this pathway, this is when we get called pediatric spine surgeons, get the spine consult typically, and that's where we need to be the experts and need to make decisions about what to do with people's craniocervical area, okay? So we've done a fair amount of work in the last several years, probably about 5 years, with computer modeling of the craniocervical junction using finite element modeling and looking at the available cadaveric literature. and sort of re-looked at this from scratch. And here are the main take-home points from a lot of work over several years. So at OC1, at occiput C1, the main stabilizing structures are the capsular ligaments. And that's an important thing to remember. It's going to drive our decision-making. The other structures, the shape of the joints, the tectorial membrane, alar and apical ligaments, they're important structures, but they're not the main stabilizing structure at OC1, and that's important to remember. At C1, C2, the main stabilizing structures are the transverse ligament, the atlantoaxial capsular ligaments, and the integrity of the odontoid, and the alar and apical ligaments are more minor or moderate stabilizing structures. So these are important things to be aware of. In the subaxial region, things change a little bit. This is sort of the slide, that sort of the classic slide that you see in pediatric cervical spine trauma talks, where the kids have large heads, underdeveloped neck musculature, more elastic joints, shallow facet joints, wedge-shaped vertebral bodies, absent unfitted processes, and so forth. So these predisposed, have everybody silent or just mute their phones if you don't mind. That would be great. Thank you. And these factors predispose children's cervical spines to more injuries than their adult counterparts. And we're going to talk about that towards the end of the talk about the demographics. So proceeding further, the cervical spine is typically broken down into two columns, the anterior posterior column. The anterior column bearing about 40% of the weight from the head, posterior column 60%. And it's important to remember in the coronal plane, the weight is borne through the condyles, through the lateral masses, and that's very important to the craniocervical junction and also further down in the cervical spine. So the concept of the disco-ligamentous complex is very important, especially we're going to talk later about the injury classification system, talk about the disco-ligamentous complex, which includes the ALL, the disc, the PLL, and in the back, the ligamentum flavum and the facet capsules. So we need to be able to recognize this and look at the images and see if there's injury there or not. All right, so I think if you asked several pediatric neurosurgeons how they were going to measure motion in a flexion and extension X-ray at the craniocervical junction, you'd have several ways of doing it, probably 10 different ways of doing this. So this is a problem, and there's a study that we put together, and it's a very simple study, and I'm going to show you the reference here in a second. But what you want to do is draw a line in front of the anterior portion of the C2 vertebral body, carry it up to the bottom of the skull, and then you're going to identify 2 points, one reference point at C1 along the C1 arch, the anterior arch of C1, and the front of the occipital condyle, and you're going to make measurements in flexion and extension and calculate the distance. So you're going to measure the distance. Let's see if this sorry. Oh, there we go. So here's from the posterior portion of the anterior arch of C1, you're going to measure it in extension. Inflation, that's like maybe minus 12. This is 0. So you have about 12 millimeters of motion between C1 and C2. This patient is not, this is not a trauma patient. This patient with osodontoidium, but this is what's, this is the concept here. Okay. And this concept, this is the reference for that article. We did it in Down syndrome. Again, you're taking this line in front of C2 and measuring the distance between the anterior arches is basically the ADI, the atlantodental interval, and the front of the occipital condyle. You do this measurement of flexion and extension, which is occiput to C2 motion, minus the C1-2 motion gives you the occiput C1 motion. So this is a validated tool, and I would recommend it highly for everybody to use. So the second tool we use is a CT scan. I'm not going to go into the details of how to read these scans, but you should have a system for reading the scan, including soft tissues and ligaments and bones, so you're not missing anything. A normal CT scan of the cervical spine is extremely powerful in predicting whether a patient is stable or not. And in fact, in the adult literature, a normal CT scan of the cervical spine is sufficient for clearance. But in pediatrics, we see more pure ligamentous injuries that may or may not be picked up with the CT scan. So we need to take that into account. However, we don't know the exact age when the cervical spine transitions from pediatric to adult physiology and biomechanics, and whether we need to rely on just the CT scan or the MRI or both to make these decisions. So let's talk, since we're talking about CT, let's talk about rotatory subluxation at C1, C2. You don't see it a lot in trauma, I mean, acute trauma, but occasionally you see it sort of in a delayed fashion. There's different methods for doing this. This is the method that I've used over the years, where you draw a line along the anterior arch of C1 and another line along the axis of the body of C2. And you can superimpose these lines and you find the angle between C1 and C2. And in my mind, if that angle is 30 degrees, or at least 35 degrees for sure, it typically means that the atlantoaxial capsules, at least unilaterally, are blown. They're incompetent, and they have a tendency to go back and revert to their sublux state. If you reduce them, say in like a collar or a halo or something like that, they can slip right back because they're incompetent. So in my mind, over the long haul, when I see kids with chronic painful torticollis, typically those children need fusion in order to get their cervical spines reduced and eliminate their pain. So that's just a concept to remember. All right, so where does MRI fit in clearing the cervical spine in kids? Obviously, there's pros and cons. There's no radiation with MRI. You can look directly at the joints, see the fluid within the joints, and you can detect ligamentous disruption. But the downsides are that there's definitely a significant number of false positives, that there's abnormalities that don't necessarily translate into instability. And we don't really know what certain signal intensities mean at certain imaging sequences at different ages. And it's really difficult when you try to pin radiologists down. It's difficult to determine how to make decisions. So here's an example with the posterior ligamentous complex. You can see reads from radiologists. It's all the way from normal to stir hyperintensity, but everything's in between. It's like a small area of stir signal change. Well, what do you do with that? And that can happen at almost any level. With the dictorial membrane, it can go from normal to rupture, but what do you do if it's stretched or lifted off? In the joint capsules, it can be completely disrupted, but there's intermediate stages where you can have high stir signal or abnormal fluid in the joint. In being able to recognize those and recognize the radiographic correlates of instability are really the decisions that we're trying to make. And those are things that I've really paid a lot of attention to over the years. So here's an example. So here's MRI in an AOD. And I really focus at the OC1 and the C1-2 joints. And on the right-hand side is a kid who was an MVA. And you can see we're going to talk about the condylar C1 interval, or the CCI. And on one side, you can see it's 4.1, 4.1, 4.1. And you're measuring this distance in the sagittal and coronal planes. It's not so bad on the other side. The MRI scan, sorry, let me go back a second. The MRI scan with the exact same slices shows abnormality in the joint, stir signal change. The patient had significant pain on motion. We weren't 100% convinced this kid needed surgery, had a lot of pain on motion, and went ahead and sort of bit the bullet. And this is this patient under fluoro, prone position with the head fixed in a clamp, and I'm gently pressing on C2. I'm going to show you this video. So this is a pure OC1 capsular injury, and you can see how much motion is there between occiput and C1. So you can see this is extremely unstable in this kid. In this particular case, launched the whole concept of the computer analysis of this area for us. So for subaxial injuries, you look at the T2 images, they aren't super impressive in a lot of ways. Here's a kid with an injury, doesn't look that bad. You can see a little bit of abnormality at 2-3, but the stir really lights up and you see that high signal posteriorly, that kind of that reverse L that points to the level in question. You got the posterior anterior column with disc disruption here. And this patient clearly needs to be stabilized. So we're going to switch decisions here a little bit about surgical decision making. And again, the seminal articles from Dr. Peng in 2007, looking at the CCI. We talked about that briefly. In his hands, in 178 joints, you can see the mean distance of the joint was 1.38 millimeters in a variety of ages in both the sagittal and coronal dimension. We started using that cutoff, and we used this for several years, and it turned out to just be too strict for us. And we ended up reviewing a large number of cases. Let me go back here a second. And this is Dockling's work showing the sensitivity and specificity of the CCI versus other methods of detecting AOD. And I think this sort of speaks for itself, and you can see Powers ratio and the Harris measurement and all these other Holy's line and all these different parameters and the high rates of false negative and false positive findings compared to patients with AOD. So I think I would use the CCI because it works. We looked at a large number of patients at our center, over 500 patients. And what was happening is that really young kids that are less than 4, for example, especially if they're 2 or 3, there's a lot of cartilage in the OC1 joint. And that distance between OC1 can be artificially high as 3.5 to 4 centimeters on average at that age. So as we showed, as patients get older, the distance decreases. Typically, when you hit probably about 4 or 5, it's a very powerful measurement of whether instability is present at OC1. So I would use the CCI definitely. So if you were going to draw a 3x5 card about OC1 and C1-2 instability, here it is for a variety of conditions, including trauma, congenital vertebral anomalies, and Down syndrome and Chiari. So at OC1, subluxation, you should have probably less than 3 millimeters of motion. Anything over 10 in a Down syndrome patient is probably abnormal. Anything over 3 millimeters in translation is probably abnormal. You should think seriously about doing something. Distraction, obviously the CCI, we talked about that. I think it's not necessarily every case, but you'd be highly suspicious for AOD in a measurement over 4 millimeters in almost any patient. At C1-2, I think most people would tolerate up to about 4 millimeters of motion in most cases. Intermediate levels are 4 to 6 millimeters, greater than 8 millimeters in Down syndrome cases. And again, we talked about rotatory subluxation, about that 35 degrees as a cutoff in my mind. All right, so that's OC1, C1, C2. And subaxial, I think we've all been exposed to this cervical spine injury classification system published in 2007 by Vaccaro. This is something that we use as a point-based system with morphology, looking at the disco-ligamentous complex that we talked about and the neurological status. We're going to talk about the types of fractures here in a few minutes. But again, it's a nice point system where non-surgical surgeon's choice and surgical cases. I'm not going to go into this in detail, but it's a tool to use. This is an older tool from White and Punjabi. I bring this up just because it starts to look at the angulation. The other point system doesn't necessarily talk about angulation, pure angulation, and what that means, because we do run into that in kids. In adults, they talk about 11 degrees of angulation, indicating instability and generating points in this particular point system. Dr. Peng has unpublished data showing that 7 degrees of angulation is abnormal. I think that the jury's still out. We don't really know. I think anywhere between 10 and 11 is probably a pretty conservative cutoff that you could use, that you'd be concerned about doing something surgically. So this is reflected in this slide, where adult versus pediatric and angulation at certain levels. and what we'd be worried about, and whether you would jump in and stabilize this patient. All right, we're going to talk about specific injuries. We got a few minutes left here. So what do we see? At OC1, AOD, condylar fractures, Jefferson fractures. People are familiar with those. At C1, C2, we're going to show some synchondrosis fractures. We're not going to talk too much about odontoid fractures, transverse ligament injuries, and you can get other injuries like weird penetrating injuries. Subaxial, obviously, you can have soft tissue injuries, growth plate fractures or separations, true bony fractures, and obviously combination injuries. So we talked about types of injuries, so compression injuries with with compression fractures versus burst fractures, where the burst fracture is going to involve the end plate here with or without retropulsion of the fragments. And these are all described in the literature, translation, and distraction injuries. These are things that kid comes in with in a particular age group. This is what you're looking for. 0 to 4 by incidence, AODs, synchondrosis fractures, ligamentous injuries. You're going to see those over and over again. A little bit older, it flips around a little bit. Ligamentous injuries, highly common. Fractures a little more prominent. AOD less common. Same thing, 10 and above, more adult physiology, more true fractures, followed by ligamentous injuries than AOD. And then anatomy plus mechanism dictates injury level. Again, upper cervical spine in younger kids is definitely going to be more prominent versus the lower cervical spine. These are old but very, very solid, good studies that you can look up. And here's a kid in an MVC. This is what happens in a kid that we're on the fence about, does he have an AOD or not? Here's a CCI 3 and a 5, 3.5. The other one's a 4. We let him go for 2 weeks and brought him back, and you can see how much motion he had at OC2. I think I got a line here. You can just barely, here's that reference line between C1, C2, and you can see how much the condyle is moving. So we went ahead and stabilized him. Here's evidence of a C2 synchondrosis fracture. Hard to see. Here's the axial. You're really not going to pick it up on the axial. You're going to see it on the sagittal here across the base of the dens, and you're going to see it in the coronal images as well. Things to be aware of. Here's a kid with a transverse ligament injury where he pulled off a piece of bone, a chip fracture off of C2, and he had a fair amount of motion between C1 and C2, and he had a lot of discomfort, so he ended up with being stabilized. Here's a significant combination injury at O1 and 1-2, and here's the MRI showing what that looks like. Here's a 15-year-old kid who went down a slippery slide, had a hyperflexion injury. Doesn't necessarily have a fracture. He's got a more pure ligamentous injury, which is unusual for an older kid. This is the T2 MRI I showed before. Clearly lights up on the STIR image, got an anterior and posterior column injury, so he required stabilization. And here's a kid who fell when the hammock support from a wall collapsed, and she had spondyloptosis at 6'7", came in Asia A, and we did her from front back. And I'm going to make a point here in a second about the power of going from the front and using the distracting posts and traction to get her back into alignment, and then supplementing that with posterior instrumentation and fusion. So real quick, I've got a couple of minutes. We're going to talk about SCIWORA. It's going on 40 years. And in the initial study, changed an entire generation of how we viewed pediatric spinal cord injury. And so if a patient comes in with a concussion, a normal CT, and a normal MRI, you don't call it a high WAR, a head injury without radiographic abnormality. You call it a concussion, right? So the whole concept originally without MRI at the beginning back in 1982 sort of made sense, but things have evolved since then, but the lexicon has persisted over time. This is sort of the biomechanical rationale, the pinching of the cord from pictures way back. And there have been studies talking about the evidence or documented cases of delayed injury, but then since these studies in the late 80s, even early 90s, there's been no documented injuries of patients who've initially been deemed to be stable by MRI or evaluation and then turned unstable. And this was revisited in 2004 by Dockling, and they talked about using SSCPs to help the clearance process, but in my hands, it doesn't necessarily work all that well. So where do we stand today? So 40 years later, I think most people would come in and they had a normal radiograph, normal MRI, normal CT, normal X-rays, some kind of neuropraxic injury. Perhaps you could call it that. Plain films and MRIs are usually all that's necessary. You can identify unstable lesions. You treat those surgically. Stable lesions with a normal MRI can be treated symptomatically. And then bracing for short periods of time can certainly be used. And then follow-up imaging is necessary for intermediate stability. So I think that concept is, in my mind at least, is a little outdated. This is just the surgical management, is how we set up our cases here, and sort of what we're looking at. Everybody knows about, at least maybe it's common knowledge. You basically, for an AOD, you just need to go down to C2. You don't need to instrument C1 or go down further. Using PAR screws, translaminar screws, pedicle screws, if that's what you choose. Anterior plating, there's lots of different choices, lots of different plates, static and dynamic plates. Most people just use dynamic plates at this point. Remember, the extracting posts are extremely powerful to reduce people, get them realigned. Usually 5 years of age, you can use adult plates. 5 years and older, you can use PEEK cages or allograft. Posterior concepts are just fine. A lot of people, that's their stabilization method of choice. I find that I can get people in better alignment going from the anterior direction, at least front. You can just restore the cervical lordosis. I find it hard from the posterior direction as a standalone case, but occasionally you need to, with a jump facet or something, you need to drill it off and reduce it to, and then you would go ahead and fuse from the posterior direction. And then we all know about the placement of the lateral mass screws. I'm not going to go into that in detail. And what about very young patients? That's what we're expert in. So here, this isn't a trauma kid. This kid with diastrophic dysplasia had severe angulation. And we wrote a little paper about using just plates with plates with single level plates or single plates with one screw in the top and one screw in the bottom. I'm not a big fan of maxillofacial screws or absorbable plates because they just don't have any structural integrity. And in our hands, this is used in both trauma and CVA and congenital vertebral anomalies. These are really, you can use these down to about 2 years of age. For super young kids, you're talking about using wire, bone, Merceline tape, and other adjuncts, probably with halo, if you were really forced to do that. So again, so my time is up. It's sort of a whirlwind tour through this. I hope you got a little educational benefit from it, and I'm happy to take questions at the end. I think we'll probably, if you want to go right into the cases next or take a few questions at this stage. Sandy, what would you like?
Thank you. That was a great talk. We always learn so much. I think we can take probably 1 or 2 questions because I know the cases are very efficient. So if any burning questions that are relevant for right now, feel free to stick it in the chat or unmute. Otherwise, I think we can actually proceed to the cases.
Hey, Doug, it's Jeff. Can you, got a question from the chat. I wanted to hear your thoughts about that. How are you approaching cervical collars and imaging in NAT, since that seems to be a lot, you know, everybody comes in, they get thrown out of the thing, you want to rest the shopping collar, they go to NAT, and sort of what do you do in that situation?
Yeah, that's a really good question. I've done that literature search many times. Actually, the incidence of cervical spine injuries in NAT is quite low. And I think a lot of kids come in with cervical spine collars on. We typically get a brain and cervical spine MRI scan. Our protocol is imaging at 72 hours of the brain, you know, after injury. So that means that the kid's sitting around for 3 days with a collar on before you clear their spine sometimes. And then plus you need to be sedated. I don't have a really good way of doing it. You know, I don't think you would flex X those kids. It's hard to know what to do with them because they're hypermobile. I think that's a study waiting to happen, the definitive study for this. And I think we could put our collective resources together to do something like this. But I do know that we're pretty conservative in this, and we do a fair amount of MRs, but again, the incidence of injury is very low, but not zero.
Great, thank you. All right, I don't see other questions coming in for now, so we're going to do 3 cases. The order is going to be Mike DeCuypere, Chris Bonfield, and Raj Iyer. So the first case will be presented by Mike DeCuypere from Lurie Children's Hospital.
Thanks, Sandy. I'm just gonna share my screen here. Can you guys see that okay?
Yes.
Okay. As Sandy said, my name is Mike DeCuypere. I'm an assistant professor here at Lurie Children's Hospital in Northwestern. And today I have a pediatric cervical trauma case. So this is a 15-year-old female who was a restrained passenger in a motor vehicle collision. She did not suffer any loss of consciousness. However, after the accident, she was complaining of a lot of mechanical neck pain. No weakness or sensory changes. She was seen at an outside ER where they did some imaging. Of note, on a little closer questioning, she had been complaining for neck pain for months, and she had seen an orthopedic surgeon as an outpatient who I guess didn't get x-rays at the time, but had ordered some other imaging that was not done yet. And then she had the accident in between. On exam, she's neurologically intact. So here is the CT and CTA that was obtained that shows an osteolytic lesion at C4 with anterior listhesis of the C3 vertebral body on C4. On the right image on the screen, you see of note, the right vertebral artery is within the vertebral foramen. However, the left vertebral foramen is essentially gone. And this is part of the vertebral artery at the anterior aspect of this mass. Obviously, we got some more or some other imaging, but first here's a coronal picture here showing the collapse of the C4 body. You can see the dominant right vert is maintained. However, you lose the vert on this side. However, it is intact. There is no stenosis or thrombosis of the artery, but you can't really see it because the vertebral foramen is compromised. These are 3D recons that I included here because I think they're very helpful and educational from a surgical perspective about planning. On the left side of the screen is the right side of the patient, where you see the vertebral artery coursing through the vertebral foramina normally. However, on the left side, you can see first that the facets here at the 3-4 level are perched, and then the vertebral artery is displaced anteriorly. So this lesion is encasing the vertebral artery and displacing it anteriorly within. Here's an MRI that shows fluid levels on the axial cut here on the right side. And you can see the vert on the left is completely encased by the lesion and displaced anteriorly, as we saw on the CTA. The right vert is okay, it's in its anatomical position, and the right facet complex seems intact. This is just a contrasted scan showing contrast enhancement within the lesion itself. So for this lesion, we're assuming this is some type of pathological fracture. The diagnosis, of course, is of paramount importance. Based on the imaging and the fluid levels, an aneurysmal bone cyst is high on our differential. We did do a biopsy, CT-guided Iyer biopsy on the front end, which did confirm the diagnosis of aneurysmal bone cyst. So just a little bit about aneurysmal bone cysts before we go on. They're benign, expansile osteolytic lesions containing blood-filled cavities with the classic soap bubble appearance with fluid levels on imaging being diagnostic for from an imaging standpoint. A lot's really not known about the formation of aneurysmal bone cysts, but it's believed to result from a either a vascular malformation that causes obstruction on the venous side within the bone, or some other process that may cause venous obstruction within the bone. And they proceed with over 3 stages of development, beginning with osteolysis, a growth phase, and ultimately a stabilization phase of the lesion. There's also a few reports in the literature of an association with malignancy within the lesion itself that's hypothesized to lead to the venous occlusion or obstruction that ultimately leads to formation of the aneurysmal bone cyst. These lesions can be found at any age. However, about 3/4 are detected before the age of 20, with the second decade of life being the most common. And can be found in any bone, most commonly the metaphysis of long bones. But obviously about somewhere between 10 to 30% are found within the spine. And they commonly present with pain or pathologic fracture. The name aneurysmal bone cyst was derived from the gross pathology. And you can see here on the left screen is a low power path slide, and on the right screen is a high power path slide. And the characteristic pathology shows blood-filled spaces that are separated by an osteoid-like tissue with osteoclastic giant cells. And on the right image, you can see these giant cells here within this osteoid matrix in between these large blood-filled channels. So treatment options in general, complete surgical resection has been the most widely used and advocated, mostly because it's believed to minimize the risk of recurrence if you achieve a gross total resection. Other treatment methods include selective arterial embolization alone, injection of other materials such as concentrated bone marrow or steroids or other osteoinductive agents, which are newer treatments that are being used for smaller lesions that don't have structural instability. The recurrence of aneurysmal bone cysts is a bit unpredictable and can be as high as 25% following surgical resection. And obviously the benefits of recurrence-free survival must be weighed against the morbidity of an aggressive spinal surgery. So for this case, as I said before, we started with a CT-guided biopsy to confirm the diagnosis of aneurysmal bone cyst. Clearly, this is an unstable lesion and will require resection and stabilization. I think you could kind of make a point to do anterior first or posterior first, followed by the other. I chose posterior first because of the vertebral artery on the left side being displaced anteriorly and encased within the lesion itself. I felt more comfortable finding the vert from posterior than I did anterior. And so that's why I chose to do the posterior portion first. Just some adjuncts I used: motor evoked potentials and somatosensory evoked potentials from a neuromonitoring standpoint, OR fluoroscopy, and allograft fusion. So these are some screen caps from the operating room on the fluoroscope. You see on the left image, this is after reduction on the table. That's about the best alignment I could get with the patient asleep on the table. The middle image is after stage 1. So we did C2 to C6 instrumentation. Those are C2 pedicle screws that we did at the top. And we resected the facet complex at C4 on the left side. And I was able to find the vert, isolate the vertebral artery. There was no significant feeding vessels. I didn't feel very strongly about doing pre-op embolization. A lot of times on a few of these that I've done, I can usually just do some sort of poor man's embolization with a little bit of flow seal or gel foam with thrombin. But it was not overly bloody after that. I was able to get lateral mass screws on the right side at each level. And then after completion of stage 1, we then, under the same anesthesia, turned the patient supine and then did a complete C4 corpectomy, resected the remainder of the lesion. Was able to find a clean margin on the right side adjacent to the facet and the vertebral foramen, and preserve that architecture on the right side, and then just did put in a carbon fiber cage, as you see on the right image. This is a post-op CT just showing the final construct from the anterior aspect or at the left image, and then you see the right and left sides on the subsequent image showing our hardware. She did quite well after surgery, neurologically intact, went home and is doing much better now. This is a 3-month post-op MRI showing no recurrence of the lesion, and she's doing quite well. So just in conclusion, about 30% or so of aneurysmal bone cysts are found within the spine in children with peak incidence in the 2nd decade of life. Lots of hypotheses about how these lesions occur. There are various genetic mutations that have been noted in various aneurysmal bone cysts. Some believe that it's a combination of random events and genetic mutations during the bone turnover phase that ultimately leads to venous congestion and aneurysmal bone cyst formation. Teenagers with these lesions often present with chronic pain or pathological fracture, as we saw in this case. Of interest, as far as the literature is concerned, there's really not many reports of neurological compromise in the setting of aneurysmal bone cysts of the spine, and they're, at least from the literature standpoint, considered a more rare complication of a fracture. However, I'm sure there are others that aren't reported, just given the gross instability that these can cause. And that is all I had. I'd be happy to field any questions.
Thanks. Okay, so if we, there's one question coming in. Did you keep in a collar post-operatively?
Oh yeah, definitely. For this kind of 360 construct, I do 3 months in a collar at minimum, and then get imaging to see how our bone effusion is going, and then I sort of slowly wean them out of the collar after that, but at least 3 months in the collar.
Hey Mike, this is Mark Proctor. That beautiful result. Did you consider fusing fewer levels than 2 to 6? Would you have considered 3 to 5?
Yeah, I guess I could have done that as well. At that time, I just with the instability I had, and I was kind of thinking, you know, sort of 2 above, 2 below kind of construct. But that's I definitely could have considered that as well. I didn't have a great reason, I guess.
Great. Okay, we'll move on to Chris Bonfield from Vanderbilt.
All right, is that in the right orientation there?
Looks great.
Okay. All right, so we have a 13-year-old female who's in a car accident, seen in the emergency department as level 1 trauma. She was intubated initially, but then extubated after she arrived. She had some small brain contusions and a little subdural hematoma on the brain scan. After she was awakened to continue the examination, she had some neck pain, but was neurologically intact. So in looking at the other images of the spine, we see an injury to C5, kind of a teardropous fracture, axial loading, compression-ish when the front is smaller than the back, but there is that small piece of bone off the bottom anterior part. There's also a sort of vertical fracture through the C5 body as well, but when you look at posteriorly, all of her joints were intact, spinous processes were not splayed, and the overall line was pretty good. So the question is in this patient who's recently extubated and has this fractured C5 is, what do we do? Do we operate? Do we not? And then if we decide not to operate, when do you follow up on something like this? So as Doug mentioned, there are some scales that we can use to try to figure out if these are more unstable or cases that we should operate on. The SLIC, subaxial injury classification system. There's a couple other ones, but this is the most simple, I think, that the people use. When we look at our patient here, we look at it mainly as we look at the top, it's compression, burst fracture, but I think it's probably a little more than that. And it's a little teardrop. I'm not going to go as far as saying that it's unstable as the 4 points show here, but it's somewhere between 2 and 4 points. The posterior ligamentous complex, at least on CT, looked good. Nothing was splayed, nothing was distracted, and she was neurologically intact. So this is somewhere between a score of 2 and 4, which is basically non-operative, or you could consider non-operative treatment there. Again, here's the picture of it, a little fracture up front, alignment pretty good, posterior elements are intact, and no splaying of the bones or posteriorly. So we decided to get filmed upright just to see what she would look like standing. When you get CT scans or other imaging, sometimes you're laying down, and then gravity comes into play, and fractures that looked all right look very different. Sometimes the neck is flexed over. There's different kyphosis. The fracture can compress, things like that. And so you always get upright X-rays before they leave to ensure that, one, things don't change, but two, in clinic, when we follow up, this is the same that we would get in clinic, so we can compare similar scans too, so it's not different scans. We decided to see her in 4 weeks in the clinic and a C-collar. She comes back in 4 weeks. She did wear her C-collar. I think that's important to know, especially when you're talking about teenagers or anybody, but did they participate in the treatment or not? She still has neck pain. She's neurologically intact, and now she's got a bit of a swan neck centered at C5 there, where the front of the C5 body has compressed even more. Posteriorly, the joints still look good. Posterior elements are still not splayed, but these definitely compressed, as now alignment is worse than it was beforehand. I got this in clinic just to make sure there wasn't anything pushing posteriorly, any bony fragments, any discs, because at this point, when we were talking about what to do, I'm going to do surgery on her, and I wanted to make sure that I wasn't going to encounter any compression of the spine that wasn't foreseen off of X-rays. That all looks good. It also shows me that when she lays down, her neck straightens out quite a bit. So I'm probably not going to have to push and pull too much in there to get her back to straight. Now we decide, is it a anterior procedure? Is it a back procedure? Is it a front and back procedure? How do you decide that? Alignment overall, I think, is one thing. How do they look when they're on the table laying on their back or on the front? How do they get back into that? Do you have to drill off joints from posteriorly? Do you have to distract and jack up the front to get it back to its overall alignment? What do the joints look like? Are they jumped? Are they perched? Do you have to try to get one over top of the other one to get it reduced? Do you have to drill one off from posteriorly? And what kind of bone quality are we looking for? Is this a healthy teenager, or if you're taking adult call, is this a 70-year-old smoker with poor bone quality where you may need to do something else? So in a healthy teenage girl with alignment that looks pretty good when she lays down supine, we decided to go in from the front, remove C5, distract, as Doug talked about, put a big cage in there. And because of her bone quality was good in the OR and she wasn't or didn't smoke, we just decided to do it up front instead of up front and posteriorly. So this is her 2-year follow-up, and we get flexion extension X-rays as well, just to ensure that, one, nothing moves in our construct, but two, overall, her neck still moves very well with this construct, and she's done nicely since then. So thanks for letting me present this case.
Thanks, Chris. Okay, Dr. Klimo asks about an MRI at the time of injury, because you mentioned it at follow-up.
Yeah, I think that you could. She just got over her head injury, and so we didn't think that it was important to put her back down on the table and sort of well, for the hour and a half or whatever it's going to be. I think it might have showed in that scan, there might have been some stir changes posteriorly. So maybe at most it adds one more point to that score. If we do think that it was an unstable teardrop fracture and some posterior elements, stir changes, maybe that puts it into 5, and you may want to do surgery up front. But in light of all of those other things that she had going on, in light of what the spine looked like, we were probably going to watch her anyway. But I think that that's something that often people will get up front just to make sure. But on her CAT scan, we didn't see any changes posteriorly, so decided not to get the scan up front.
Okay. All right, maybe we'll save that question for later. Okay, we'll move on to Dr. Raj Iyer from University of Utah. He'll do the last case, and then we will see if we have time for general questions.
Can you guys see my slides? Is the appropriate?
Yes, we see your PowerPoint screen.
So thanks for the opportunity to present. I'm just going to switch gears today and present on a case a little bit further down the spine. It's a 15-year-old boy who was playing on the monkey bars and tangling his legs, and then he suffered a fall and landed directly on his back. This was 3 to 4 weeks prior to presentation. And he was ambulatory afterwards, but he had a lot of back pain and also actually had some left-sided radicular pain into the posterior left thigh. And ultimately, his pediatrician got an x-ray that was concerning for a spine fracture. So he came in for further evaluation. He was otherwise healthy and interactive, and he was full strength in the lower extremities, except for some pain-limited weakness, 4 to 4+ in strength in the left iliopsoas. And so here's his imaging. We got a CT scan for him after an x-ray was done, and that demonstrates a T12 burst fracture. And you can see here that, sorry, is that advancing? There we go. So you can see here that he's got a burst fracture at T12. And if you extrapolate the spinal canal, you can see that there's retropulsion of those fragments as well of this burst fracture here. And I think it's important in these situations also to get upright films. This child was ambulatory, and you can see on his AP and lateral films, overall his global spinal balance is pretty good. Head over his chest, over his pelvis, over his torso. But in the regional films, in terms of his thoracolumbar region, he has a kyphosis of 26 degrees there. And as we look at his regional films here, you can see that that's an abnormal thoracolumbar kyphosis as well. So focal kyphosis going on associated with this fracture. On his imaging, you can see here on MRI that there's cord compression, really at the level of the conus, maybe some cord signal change as well. And you can see again that's demonstrated on his MR imaging and axial slices. So I took him to the operating room and did a T10 to L2 posterior instrumentation infusion in this particular situation, given that he had a radiculopathy and maybe some weakness of the left side. Did perform a T12 laminectomy as well as a transpedicular decompression for ventral spinal cord decompression. His rods were contoured in the ideal sagittal alignment for the thoracolumbar junction, so they were somewhat under contoured compared to what he showed up with, and used cantilever and reduction screws in order to help correct his kyphosis. And so this is a post-op result here. You can see after a T10 to L2 posterior spinal fusion and laminectomy. And I think in these situations, when the cord is compressed from a ventral standpoint, intraoperative ultrasound with transdural ultrasound is useful. And you can see here that pre-decompression, after a laminectomy is done, you can see that his cord's pretty flattened ventrally. And then post-decompression, you can see that, that the cord has regained its cylindrical shape. And so in this situation, one might ask, do you need to decompress ventrally like that? Do you have to do a transpedicular decompression? And one of the concepts that many people use out there is what's called ligamentaxis, in which you can use a longitudinal distraction force with an intact PLL in order to provide an indirect ventral decompression of that fracture fragment by compressing on your screws, actually. And in this situation, we didn't do that because the key is an intact PLL for this type of situation. And you can see here on his fracture and his MRI that the PLL was disrupted there. And so we didn't utilize that, but post-operatively, you can see an improvement in his thoracolumbar kyphosis there and good satisfactory implants there. And so thoracolumbar burst fractures in general and in children, they're often due to axial loading injuries or flexion injuries. If they're stable fractures, they can be observed and braced, but the decision for surgery really rests on the fact whether you need to do a decompression for neurological compromise, as well as the need for stabilization or deformity correction, as in this case, and also determining the likelihood of healing with or without intervention. And so the Denis 3-column model of spinal injuries really looks at 3 columns, anterior, middle, and posterior column, and that's kind of developed into a little bit more extensive classification schemes for spinal injuries. And that includes compression versus distraction versus translation injuries. In this particular situation, this was a type A3 or incomplete burst fracture. But also there's been a adoption of really the thoracolumbar injury classification and severity score, which is called the TLIC score, which is complementary to the SLIC score that Dr. Brockmeyer and Dr. Bonfield mentioned. And in this case, you look at the morphology, the neurological involvement, and the posterior ligamentous complex. And so this was a burst fracture with either a nerve root injury or an incomplete cord injury, as well as maybe suspected posterior ligamentous complex injury as well due to splaying of the spinous processes. And so in that situation, it's likely an operative situation. This has also been kind of confirmed in children and validated via multiple studies that have been published recently. And so overall, the TLIC score, although is validated in adults and created in adults, has good reliability in children as well. And so I'll just stop there. Thank you.
Thank you. Beautiful cases, like great results, and really well presented, everybody, and just awesome trip down the spine. So thank you. All right, so Chris Bonfield wrote, laminectomy can also easily be expanded to involve a facetectomy to help with kyphosis correction. Okay, there is a question, did the, Raj, did the preoperative x-rays in this case change your decision-making or your operative plan?
Yeah, I think that, part of the indications for surgery in the thoracolumbar junction is that junctional kyphosis. And I think that, overall this child's global spinal balance was okay, but over time that can worsen. So that is part of, I think, my rationale for doing surgery in this child.
Great, okay. And then I think that this actually deserves a comment from Dr. Brockmeyer. There was a kind of side chat from Dr. Salehi about approach to wiring or other surgical techniques for very young kids with AOD. And Dr. Brockmeyer wrote about using rib and cable and screws. So I think it'd be great to hear from Dr. Brockmeyer directly.
Yeah, thanks, Sandy. My lower threshold for starting to think about par screws, at least reliably solid par screws, is probably about 2 to 2.5. It depends on the child. So a normal kid comes in, and sometimes I've snuck them in as young as kids 16 months of age with AODs. Definitely have several of those cases. That's not everybody's cup of tea. I understand that. So I think like if you're talking about a year and a half, maybe up to 2, structural rib graft, you're using a cable or you put, screws through the top and bottom of the rib and into the occiput and push the arch of C1, put them in a really good halo. I use BMP fairly liberally in that area. I use extra small kits, and I cut little pledgets and I put them at the contact points between the rib and the skull and the rib and C2, kind of like a little sandwich. And I use the smallest amount I can possibly use, and had good results with that, with low side effects. I mean, most kids would fuse without BMP anyways, but for me, I only want to do it once. So that's why I use the BMP a lot.
Great, thank you. We have 1 minute left, right on time. It's been a wonderful session. Thank you to all the speakers, definitely Dr. Brockmeyer. And I think Dr. Leonard might have some closing remarks and talking about next time.
I want to thank everybody for a nice educational session and a sort of a trip down the spine, as Sandy referred to. Again, this is a nice continuation of the educational seminar. It will continue again in approximately another 2 months, dealing with spina bifida. So I appreciate everybody's attention and everybody attending, and hopefully they find this useful. Again, in reference to the quality, this, as you see, the attendance, exceeded 40 for this time. And, that's very commendable. And thank you, Doug, and Sandy, for your organization of this and participating in this trip down the spine. Again, thank you very much, and everybody have a good evening. Good night.